Otosclerosis and tinnitus. Here we can see the diagram of the external ear, middle ear. This is the malleus, this is the head of the malleus, this is the handle, this is the tympanic membrane, and this is the body, the short process, this is the long process, and this is the head of the stapes, the lenticular process, and this is the oval window, this is the round window, and this is a tympanic cavity. There is a eustachian tube opening. Now the introduction, the otosclerosis. Well, otosclerosis, it is a primary metabolic bone disease of the otic capsule and ossicles, resulting in fixation of the ossicles and conductive hearing loss. May have a sensorineural component if the cochlea is involved. What is an otic capsule? It is a bony labyrinth. It has three layers: the endosteal, the endochondral, and the periosteal. The endosteal, it is the innermost layer. It lines the bony labyrinth. Endochondral develops from the cartilage and later ossifies into bone. It is in this layer some isolates of cartilage are left unossified that later give rise to otosclerosis. Periosteals cover the bony labyrinth. Here you can see in the diagram, this is the otic capsule. So the outermost is the periosteal, then comes your endochondral, and then the endosteal. Well, in this endochondral layer, where this you can see the unossified cartilages are left, which later lead to the formation of otosclerosis. Now, what are the types of otosclerosis? First is the stapedial otosclerosis. Well, it causes a stapes fixation and the conductive deafness. It is most common variety. Lesions start just in front of the oval window in an area called the fistula anifenestrum. The types of the stapedial otosclerosis. Well, types of the anterior focus, the posterior focus, the circumferential biscuit type, and the obliterative type. Anterior focus, the fistula anifenestrum, anterior to the oval window. It is 90% of the cases this is seen. In the posterior focus, the lesion may start behind the oval window. 5 to 10% of the cases we see this. So in the anterior focus, it is a fistula anifenestrum, and it is anterior to the oval window. Posterior to the oval window, it is a posterior focus. Circumferential, it is the around the margins of the stapes footplate. In the biscuit type, in the footplate, but the annular ligament being free. So in biscuit type, the footplate is involved, but the annular ligament is free. In the obliterative type, completely obliterate the oval window. So here we can see the types of the stapedial otosclerosis. The anterior type, the posterior focus, the circumferential, the biscuit type in which the annular ligament is free, and the obliterative type. Now, what is a cochlear otosclerosis? It involves a region of the round window or other areas in the otic capsule and may cause the sensorineural hearing loss, probably due to the liberation of toxic material into the inner ear fluid. Then the histological otosclerosis. This type of otosclerosis remains asymptomatic and cause neither conductive nor sensorineural hearing loss. Now, what is the etiology? It is basically autosomal dominant and hereditary in 70% of the cases. 1% Caucasians with symptoms are involved, autoimmune disease, and Van der Hoeve syndrome, osteogenesis imperfecta, otosclerosis, and blue sclera. This is the syndrome which basically consists of these three things: the osteogenesis imperfecta, otosclerosis, and blue sclera, and measles. So these are the conditions. This is the etiology. Well, the etiology related to measles. The possible pathomechanisms in otosclerosis: the measles virus infection via the eustachian tube, the penetration into the bone or the labyrinth via the oval round window, perivascular space, lymphatic vessels, infection of the fibrocytes, chondrocytes, osteoblasts, expression of the MV antigen at the cell surface, cellular and humoral immune response, and as a result, the inflammation causing the otosclerosis, resorption lacunae. And the final stage is scar formation, dense new bone formation. This is otosclerosis. Now, when we talk about the pathology, the two phases of the disease: the active osteospongiosis phase and the mature sclerotic phase. In the otospongiosis active phase, the active resorption of the bone and dilatation of the vessels. Whereas the mature sclerotic phase, the deposition of new bone, the sclerotic and less dense than normal. So the sclerotic and less dense than the normal bone, and is chalky white. What are the symptoms? Basically, the conductive hearing loss due to the oval window sclerosis, where the sensorineural hearing loss, hyalinization of the spiral ligament and toxins, which is most commonly seen in cochlear type, Vestibular symptoms like the degeneration of the Scarpa's ganglion, soluble toxin substance direct invasion, tinnitus seen in cochlear otosclerosis and in active lesions. Paracusis vilsi and O2 sclerotic patients hears better in noisy than quiet surroundings. This is because a normal person will raise his voice in a noisy surrounding. Now the history taking. Well, the age of onset of hearing loss is 20 to 30 years. Progressive, solely progressive. And the associated symptoms are dizziness, otalgia, otorrhea, tinnitus and paracusis vilsi. In history taking, we have to rule out all these things, take out. Well, in the history, the vestibular symptoms are present in 25%, most commonly in a disequilibrium, occasionally attacks of vertigo with a rotatory nystagmus. Periodic otologic surgery. Well, in history, we have to take all these into consideration: period, otologic surgery, history of the ear infection, family history, to have a significant family history. As we talked before, the 70% of the cases, it is autosomal dominant, and 70% of it is hereditary. So, particularly helpful in the patient with severe or profound mixed hearing loss. Now comes the physical examination. We can use the pneumatic otoscopy. In the otomicroscopy, the most helpful in ruling out the other disorder like the middle ear infusion, tympanosclerosis, tympanic membrane perforation, cholestoma, or the detraction pockets. Well, what is the Schwartz sign? Well, the reddish hue over the promontory seen in 10% of the cases. Now, if we talk about the physical examination, we can do the Rini, Weber, and ABC. When in Rini's test, we can use her 256 Hz, 512 Hz, and 1024 Hz tuning fork. But one must understand this thing that negative test indicates at least 20 decibel airborne gap if you are doing with a 256 Hz. And in 512, the negative results indicate at least of 30 decibel ABG. Whereas in 1024 Hz, the negative test indicates at least 45 decibel airborne gaps. And Weber's is always lateralized to the ear with a greater conductance loss. ABC may be normal. It is decreased in cochlear otosclerosis with sensorineural loss because it is a test of the bone conduction. Then a differential diagnosis, there are ossicular discontinuity, the congenital stapes fixation, Malleus head fixation, Paget's disease, osteogenesis imperfecta, adhesive otitis media. In audiometry, the impedance audiometry, one must note that in otosclerosis, there is a progressive stapes fixation results in AS type of curve due to reduced compliance at the ambient pressure. So here you can see this curve will be seen in otosclerosis. And always remember that a patient with the early disease may show type A tympanogram because the middle ear aeration is not affected. Then progressive, it lead to AS type of curve. Then comes the Puritan audiometry, the most useful audiometric test for the otosclerosis, characterized by severity of the disease and frequency specific. Low frequency. Always remember in otosclerosis, the low frequencies are affected first, below 1000 Hz. As you can see, the low frequencies are affected first. The airline flattens with disease progression, and the Cahart notch hallmark audiologic sign of the otosclerosis. You can see the dip at 2000 Hz. So, this is the hallmark in otosclerosis. Well, in imaging, the computed tomography of the temporal bone pre-op to characterize the extent of the otosclerosis. Severe or profound mixed hearing loss. Evaluate the enlarged cochlear aqueduct. And in the post-op to evaluate the prosthesis dislocation and vertigo. Here we can see the otosclerosis. This is the malleus, this is the head, this is the handle of malleus, this is the incus, long process of incus, this is the stapes which is otosclerosed. The management is the medical, amplification, surgery and combination. In the medical management, it is sodium fluoride. Mechanism: fluoride ion replaces the hydroxyl group in bone forming fluoroapatite. It is resistant to resorption, increases calcification of new bone, causes maturation of the active foci of the otosclerosis. Now sodium fluoride, it reduces the tinnitus, reverses the Schwarzschild resolution of the otospongiosis seen on CT. Dose is 20 to 120 milligram. Indications non-surgical candidates and surgical candidates with a Schwarzschild. Treat for 6 months pre-op. Hearing results 50% stabilize, 30% improve. Re-evaluate for 2 years with CT and for Schwarzschild to resolve. Then the medical में bisphosphonates, it inhibits the bone resorption by inhibiting the osteoclastic activity. Whereas the sodium fluoride was doing, sodium fluoride was basically inhibiting, it was replacing the hydroxyl group. It was the fluoride ion was replacing the hydroxyl group in the bone forming fluoroapatite. Whereas bisphosphonate, it is inhibiting the osteoclastic activity, often supplements with vitamin D and calcium. Studies conducted on the otosclerosis patients with the neurologic symptoms report the majority of the patients with subjective improvement or resolution. Well, amplification, conventional hearing aids and bone anchored hearing aids can be used in otosclerosis in amplification. Well, in the surgery, we have the stepidotomy and the stapedectomy. In stepidotomy, a limited opening hole within the central footplate of the stapes accomplished via the laser or manually with a drill is referred to as the stepidotomy. Whereas stapedectomy, total or subtotal removal of the staped footplate, usually accomplished manually, is referred to as stapedectomy. What is the best surgical candidate? Air conduction levels 45 to 65 decibels, bone conduction levels 0 to 25 decibels. Airborne gap 15 decibels and discrimination score greater than 60%. The factor affecting the stapes surgery is the audiometric profile, the skill of the surgeons, facilities and medical condition of the patient. Well, the other factors are the age of the patient, elderly, congenital stapes fixation 44% success rate, occupation, driver, pilot, vestibular symptoms, Meniere's disease and combinated otological disease costoma. So we have to watch out for these symptoms and then rule out a candidate for the surgery. Now these are the steps of the stepidotomy. Here we can see the anterior canal injection is given, the tympanomeatal flap is elevated, the chorda is separated from the manubrium, and here we can see the curate furrow is used and a bone is removed. Then we can see by measuring the medial aspect of the long process of incus to the foot plate. This is the measurement of the processes is done with this instrument. We have to note that there is a wide variety of stapes processes are available and only few of them are shown here. These are the processes used. On the left is a prosthesis that is fits under the incus with the lenticular process sitting on the bucket. The wire handle is then flipped over the long process of the incus. You can see this flipped over the long process of the incus for additional stabilization. The other processes are the pistons of different configuration that are placed through the oval window and cribbed over the long process of the incus. The materials used is virtually all prior and all current processes are MRI compatible, stainless steel, platinum and Teflon. And then after that, after measuring, then we can remove the stapes bone. The stapes bone is removed, the stapes footplate is opened. The vein graft covers the opening of the footplate. The process is placed onto the incus, the process is resulting in the vein graft. So as we can see in this, the stapes bone is removed, the stape footplate is opened. So what is the difference between the stepidotomy and the stapedectomy? In stapedectomy, the whole stape is removed and then a hole is drilled and the graft is placed, the prosthesis resting on the vein graft. You can see here. The main difference between the stepidotomy and stapedectomy is that stepidotomy only a hole is made and the prosthesis is fit. But in the stapedectomy, the whole structure, the stapes is removed, the footplate, and then a hole is made. So this is the basic difference. Now the drill fenestration. A 0.7 mm diamond burr is used. The motion of the burr removes the bone dust, avoids smoke production, and avoids the surrounding heat production. Laser fenestration, the first laser stapedectomy performed by the Perkins in 1978. Less trauma to the vestibule, less incidence of processes migration, and less fixation of processes by scar tissue. Types: argon and potassium titanyl phosphate (KTP). The wavelength is 500 nanometer and is surgical and aiming beam. The carbon dioxide is a 10,000 nanometer with the ill-defined fuzzy beam. Well, the oval window seal is used by the vein, the hand, or the wrist of the temporis fascia, fat, tragal perichondrium, or the gel foam. The total stapedectomy. The indication of the extensive fixation of the foot plate, the floating foot plate. That is, advantages are the increased post-vestibular symptoms, more technically difficult, and increased potential for the processes migration. This we can see again the steps of the stapedectomy. How the stapes is removed, the superstructures are removed. Superstructure is removed, then the stapes is removed, and the drilling is done, and the process is fitted. So what is the basically difference between the stapedectomy and the stapedotomy? The better stapedectomy is a better low frequency hearing gain, whereas the stapedotomy better high frequency hearing gain. Decreased perilymphatic fistula. The chances of perilymphatic fistula is decreased, and decreased sensorineural hearing loss and decreased vertigo. The chances, but these chances are greater in the stapedectomy, but the better low frequency hearing gain is seen. Now let us talk about the tinnitus. Which will be talked in the next video.